people are about to come on. So, hey, Mark. Won't turn on. Hi.
Hi,
Oh, where'd you
what
get that
doing
mask?
here? Where'd you get those scrubs?
I know, for
Don't she look
student
fine?
stuff. I know I got these to wear with the regular blue, just didn't go. I'm gonna be back there. I'm doing clinicals for like an hour virtually through Zoom. It's just not working. Oh, participants. See, like she's about to come in.
Okay. So this is the result.
Yeah, we did it already the other day. Hi.
So you're officially working.
I know, but they're
getting
still
paid.
paying us like 8 hours a week. They just have to do it for an hour, and then we're just splitting stuff like that first day clinical.
Hey,
I haven't seen you in so long.
I like your scrubs.
Thanks.
Where'd you get those?
That's someplace close to where I live.
They let you wear them there?
Well, it's just like student day. Like I got this a long time ago to wear with that, but it does not go. Like with this, I got navy pants and matching just to do the clinical stuff whenever they're here, but they're not here. But I'm doing clinical stuff today with them.
Like on FaceTime or something?
Yeah, Zoom.
Oh, nice.
Yeah,
Zoom. So
it is. It is
those are
pretty
good
neat.
scrubs, though. Those look good.
I know.
I
like those.
like them.
They look like shiny.
Thanks,
They
guys.
look- They look like
They're
Are
new.
they Skechers? I have some.
Yeah, the pants are Skechers.
Yeah.
I just want to get Skechers pants all the time.
I have
They're so
some.
comfy.
Yeah.
I'm still waiting for one more person.
What are you guys covering today?
Well, since just an hour, the first day we covered like nasal cannula, high flow CPAP stuff, and then today is tube depth and size and suctioning and sat limits and gases. And since it has to be an hour, I also pulled up a ventilator to start pressure control stuff and looking at an X-ray and deciding on the gases with just the pressure control area. Because then Heidi's going to go into auto mode with PRVC, pressure control, and maybe introducing NAVA, and then I'm going to do NAVA, and then one of us is going to do oscillator. So it's going to,
Actually, take her to the bedside at some point.
with this, I don't think it's allowed. I have to like cover it up with stickers. Like Zoom isn't like, I don't know if anybody can hack in it and get patient information, so you're not really allowed to like,
There's a.
But just to go to see the ventilator is in patient room.
into the room. Right. Oh, I thought you said to go into the patient room. I'm like,
You
you
can go to
can't.
the patient room, but you keep yourself shielded and then
Oh,
just go to show
that's
them
true.
the ventilator to
There's a
see
thing called
the actual
Well,
process.
good ideas.
There's
Okay.
a thing called telehealth. That's like a FaceTime, like counselors and stuff are using that.
Mhm.
Therapists and stuff are using it right now, like
Yeah.
for FaceTime because it's HIPAA approved.
Yeah. It's
Keep
kind
it
of like
shiny.
daycare anywhere.
Yeah.
Yeah.
They're using Kilo, so.
All right. Yep. No. Hi. Can you hear me? I can't hear you. Huh. Let's see. Can you hear me? No? Hold on, I can't hear you. Okay, let's see. I see that. Chat, disconnect. It says audio is on. I don't know what to do. Can you hear me? How about now? Can you hear me? Damn. Oh, how about now? Can you hear me? Damn. I can't hear you. No, I still can't hear you. Damn. Crap.
Now I can hear
Yes.
you.
Perfect.
Sorry.
All right. Where's our friend at?
Jonathan, I thought you said it was going to be Tuesday.
Oh. I think
don't know.
Heidi's is Tuesday and I'm Monday.
Oh, I don't know. He doesn't pay attention much. I always got to tell him. I always got to tell him stuff.
Oh, okay. Well, that's okay. We'll go over stuff and
Okay.
we could quickly catch him up, or maybe you can catch him up.
All right.
Perfect. So before we go into too many vent modes yet, we're going to go over gases and tube size and depth and the NEOT. Do you remember using the NEOT?
Yes.
Cool. So I'll just go over that just a little bit and show you our airway bag and such. Also just kind of introduce you to pressure control. It's not a mode we use a lot, but I have it in here just to get you started and kind of just introduce you to all the vent modes. But anyways, all right. So, you know, here in the NICU, we don't use really pounds or their height to determine a tidal volume. But we use their size, and we usually use their size in grams. So, kind of refresh you, like if we have like a micro preemie, like around a 24-week or so, they're going to be under 1,000 grams, and 1,000 grams is 1 kilo. So that's easy to remember. So right now I have this chart. Can you see it?
Yes.
Yeah. So it says 1, 2, 3, 7, 8, 9. So the 1 right here represents 1 kilo or 1,000 grams. Okay. So if a baby is under that 1,000, we usually intubate them with a 2.5 tube, and we usually shoot for 7. Now, if it's like a really micro preemie baby that's around 600, 700 grams, that's really tiny, we would always use a 2.5 tube, but we wouldn't necessarily shoot for a 7 of a depth, only when they're closer to 1,000 grams. So I would shoot more for like a tube depth of like 6, 6.5 in that situation. Now, once babies start to go over 1,000 grams, we usually can upgrade them to a 3.0 tube, and we shoot for 8. So that's why in my head, whenever I have an assignment or looking at the tube depths and the x-rays and such, I always think in my head 1, 2, 3, 7, 8, 9, and it's the easiest, quickest way. Because these are the 3 main sizes you're going to use. You're going to use a 2.5 tube, a 3.5. Occasionally we have a 4.0, but it has to be a big moose of a baby, and that's really rare that we have that. I'm just keeping the computer open. So again, kind of like once you reach over 1,000, once you reach over 2,000, you're allowed to have a 3.5 tube, and that's when you shoot for 9. So for instance, if I have a 1,500 gram baby, or for 1.5 kilos, I would go a 3.0 tube and shoot for about 7.5 on the tube depth. So this is super important. Whenever we have an assignment in the NICU and I have several intubated babies, I look at, obviously when we give report to and from each RT, we tell them, or they tell us, the tube depth and size. And that's something that has to correlate with us. That's on our sheets. It has to correlate with a, oh shoot, somebody's coming in, hold on. Sorry. Hi, no, you're good. Anyway, so can you tell me, I forgot what we were going through. Oh yeah, everything has to kind of like match up. So every time you get a tube depth and size and report, or when you see it on the x-ray, or when you're initially intubating, you have to just be on the same page. So you'll know exactly where to put that tube for each baby. You understand?
Yep.
So if a baby accidentally extubates, you have to remember exactly which babies have what size tubes and depth. And obviously if you have several babies that are intubated, it can be confusing on whose is where. So it's the 1, 2, 3, 7, 8, 9 is a really fast, easy way to be able to determine. All you need is their weight. So it never ever goes by their height or their length in centimeters. So can you tell me what tube size and depth a 2,500 gram babies would be?
2,500.
Mhm.
3. It'll be 3 kilos, and then the depth will be 9, right?
So you mean the size of tube?
Sorry. I was reading it wrong. The size tube is 3.5, and the depth will be 9.
Absolutely. Yeah. So for 2,500, I would shoot from anywhere between 8.5 and 9,
For the
somewhere in the
high.
middle. Now, it may seem absolutely like ridiculous, but just going from 8 to 8.5 is huge. Like that can determine a baby being right main stem, like that little itty bitty bit. Sometimes we even like will untape a tube to retape it, and it's just like a 1/4 of a centimeter of a difference. So it can be pretty crazy. So that's why it's super important every time we have hands-on or anything, make sure to look at the depth. We have neo bars. I can show you a little bit later. They have we call it tension. So a lot of the time when that tube holder's on there, it can move up and down a lot. So you can see the tube depth fine when the baby's on their back, but when they move to their side, it can be in a totally different spot. And it's up to us to determine if it's in decent position or not, or if you have to retape it. Yeah, so that's good to remember, and I'll quiz you in a second about that, just to get your mind remembering, because it's super important here. Okay, then we're gonna go on to, I'll show you this little suction piece. So I actually attached it to a NEOT. You can just pretend this is a vent tube, and it's hard to see the numbers, but have you done PICU stuff yet?
I have. And
Okay.
I work at Advent Health, so I'm familiar with all the stuff that you're saying because I'm always touching it and all that stuff.
Oh, beautiful.
So
That's
know.
perfect. What do you do there?
I'm a respiratory tech, so I deal with the supplies, tanks, and the equipment. I break them down, set them back up, and all that stuff.
Nice. What vents do they use there?
They use Dragers for the babies.
Okay. That's awesome. Cool. So it'll be a little new to you seeing a servo N, I guess, but you have it at the school. You have the servo U and the servos.
Yeah, and then I did my clinicals at TGH, so I'm familiar with the servos.
That's really good. That's awesome. You have a leg up on some people.
Yeah.
Awesome. So when we
very fortunate.
Yeah, that's awesome. So when we suction with the babies, I'll just review it. I don't know if you know this or not, but we have obviously the depths right here marked on the tube. And then on this catheter, we have different colors. Do you see the colors? So by each color is a number of centimeters. So with the babies, when we suction, it's not like in the adults where you just ram in the suction catheter until you feel resistance and then suction, because our babies are extremely prone to vagling, really easy and bradying. So we try to get just what's at the end of the tube every single time we suction. And it affects them a lot. Every suction, you're taking away a lot of air as well, obviously. So they're a lot more delicate when it comes to suctioning. So what I mostly do, in my opinion, since a lot of the times even the rooms aren't as bright and they're a lot more dimmed for the babies, I usually get the red one. And where the red depth, there's a 12 by it. So every single time I suction, I push it in until that red matches the 12 on the tube. And you see how the suction catheter doesn't really go beyond the tip. And then we usually stay down and suction for a few seconds and then come out. A huge mistake a lot of people do, and I mean, I get it because a lot of people are kind of scared because there's these tiny little babies, is that they'll go down to suction and then pull it out as soon as it's in, and that's not going to do anything. So, and I know people get so kind of nervous as well, but that's always just the proper way to suction. So even if you're in a hurry, you really got to see exactly where that tube depth is and mark up the 12 here and the 12 over here, or you can pick any other number. It's just the easiest to see in the red. So since I have the NEOT in my hand, I'm gonna attach it just so you can review it a little bit. There we go. All right, so with the NEOT, do you remember how many liters you start with the flow?
No.
All right, so I just attached it to the flow meter on the wall. And
wait. Are we like 40? Is that too high? Is that the high end?
Too high. So the flow coming from the flow meter, so you don't even have that on adult flow meters.
You're talking about the 0.5 Like it's a really small number, right?
No, that's when they're on a nasal cannula.
Oh.
Okay,
No,
so
I
this
don't
is
remember.
their, it's okay, that's what we're here for, and we can learn. So this is obviously our resuscitation device. We also have our self-inflating bags, our flow inflating bags, and we have this. So when I attach this all the way to the wall, we start at 10 liters. And I know compared to adults with the Ambu bags, that y'all go all the way up to flush on an oxygen flow meter, yeah?
Yes.
So we rarely ever have just oxygen flow meters. That's the ones I showed you last time. We have to pull those out of a special drawer. So they're not even on all of our walls. So when we have this attached to our walls here in the NICU, it's attached to a blender.
Mm-hmm.
So when if I'm full on resuscitating a baby and they're coding, I would turn that knob all the way to the 100. And that's something that people forget all the time because they see flow meter, you pop it in, you try to resuscitate them. But in this situation, we always have to remember to give them oxygen. When they're coding, we don't care how much oxygen. You got to give them the amount of oxygen they need at that moment. So once that's set at 10, we have this knob, and this is our pressure manometer. So this has the green, yellow, and red, and the higher it goes in the colors, the higher pressure you're going to get. So I'm turning the dial all the way to like the yellow. So it's going right here. And then right here, this is our PEEP. So when I cover this up, you see how there's PEEP on there, how it's at this right here? And then if I move it, the arrow goes down. Are you able to see all that?
Yes, I can see it.
Oh, sweet. I'm just making sure. All right. So since I had gone up on this knob right here, when I push down, I'm able to get a certain pressure. What's that pressure reading on the arrow?
20.
Okay, that's perfect. We usually start with like 20 over 5. So if we're at a delivery and we have the warmer and everything we need, we set up the NEOT and we have it 20 over 5. Now, when we're resuscitating a baby and we're bagging the baby, so if it's bag mask and it's PPV, and we are giving the baby the breaths just like this, we're getting 20 over 5 and we're breathing for the baby. Something that we usually have to always look at, well, not usually, but all the time, is their chest rise. So if their chest isn't rising and we need more pressure, you automatically go to this thing right here and you go up on the arrow. Did you see it go up now?
Yeah.
What's it reading now?
It's between 25 and 30.
Yeah. Perfect. So then if you're still at a delivery, let's say the baby's not oxygenating, we have them at 100%, we're still giving them breaths, they're getting their chest rise, and you want to go up on their PEEP. What's that PEEP reading?
Do it. It's between 5 and 10, so it looks like 8, maybe.
8, okay. So sometimes, so right now, when I was pushing that around to get more PEEP, the knob, it stopped right there. So that's as much PEEP as I can get right here. But if I wanted to get more PEEP, what's something I can do?
Can you twist that knob for the pressure or no?
Right here? No, the pressure's only going to do your inspiratory pressure. This is only the inspiratory.
For PEEP?
Yeah. Yeah. It's a hard question.
Flow.
Yes.
Flow?
Yes, absolutely. 100%. You're a badass. Yes. The flow. So I just went from 10 to 15 and look how much PEEP is reading.
Yeah.
So that's just the PEEP. So now I can finally like go down and go to 10 if I wanted to, you know, if we needed to do 10. So just doing that, that's why it's so intricate and so super important to be able to pay attention and actually know how to use this. A lot of people, they're like, oh, that's easy. It just gives your pressures and you press it. But if you don't know how to use it and when to go up on your flow or how much you need to go up on your pressure, you can really like hurt a baby and do some huge damage and cause some terrible pneumos. But it's really good because you get the same pressure every single time. Okay. I wish you could play with it and touch it.
Yeah. I only deal with it in packages. I don't really open it and deal with it.
Yeah, I wish I were here to be able to touch it. So yeah, so pressure and then your PEEP. And if you need any more and it's not giving it to you, you just go up on the flow.
Wow.
Yeah. All right. So I'm going to show you our intubation bags for a sec. I wonder if I can turn this around. Oh, I just saw my face. Nope, I can't. Oh, here we go. Camera flip. Ah, yay. All right. Whoa, are you still here?
Yeah, I'm still here.
Okay, sorry. It glitched for a second. All right, so I know a lot of places that you've probably seen have a lot of like intubation carts in general, especially the PICU, but we have this red bag in every single one of our neighborhoods. And it's our responsibility to check these bags every single time we come onto our shift. So these are what our handles look like to intubate. And then we have our 3 size blades. So you know how we have, let's see. Never mind. So our a lot of our things, when it comes to sizes, we have sizes 0, 1, and 2, and such. But anyway, sorry. I'll show you this. So this is a 1 size blade, and that's how big it is. We never ever really use it. It's really rare. And then we have a 00 and a 0 blade. We also have a 10 French catheter. So I know a lot. Compared to adults, you guys have a Yankower. Well, we have like little neo suckers, and we have a 10 French. So, you know, when we were talking about bubble CPAP earlier, and we have to make sure their mouth is closed, and you have to make sure they're getting all that pressure and that's bubbling. So sometimes when you're at a delivery and you're using the NEOT and you're just putting the NEOT on the face, giving CPAP, you're not pressing the button to get pressure. A lot of that time when you're just giving CPAP or even PPV, you get a lot of air in the belly. So when we're at a delivery, we actually use this 10 French catheter a lot, because a lot of that air is going into the belly, and the more air that's in the belly, the less their lungs are able to expand for them to be able to breathe. So this is something that's really important. Every single time we have an intubation, whether you're in a hurry or not, this is something you need to throw down onto the bed along with the blade and the handle and everything. And then we have our stylet. We only have 1 size, and this is it. And then we have our 3 size tubes. This is the 2.5 tube. And then over here to the 3.5. We have some of these just like we do in the adults, except they're just a little bit smaller, the end titles. Obviously, we need that every single time. And then we have our different size masks in here. Those are, again, there's 1, 0, and 00. 00 being the smallest one. So it's pretty awesome when you guys become like familiar with these bags, and then you guys have an assignment in the NICU when you're at clinicals and you're able to grab everything like that for us, because I've had that situation several times and it's that much of an emergency, and you guys have been actually a huge help. Let me think, what else do we need to cover before we get into, okay. Oh yeah, talking about oxygen. So this is something else I'm going to write down for you to be able to see. What time is it? Okay, cool. All right, so for certain size babies, I wish I had a whiteboard. Let's see, if they are under 36 weeks, over 36, let me just write this down for you for a second. Air, 8, 02, sorry, hold on 1 second. Okay. All right, so, all right, you see this? All right, so SAT limits are super, super important. Obviously, when the baby's not coding or anything, or of that matter, we always try to limit their amount of oxygen, because a lot of babies do get ROP. We actually have a doctor that comes in every Tuesday from Miami that does the eye exams. So what that oxygen does, it prevents their blood vessels. It constricts them and prevents them from growing properly because they're already premature. And it can cause blindness. And so there's 2 things that a doctor can do. They do laser eye surgery, and they do, God, what it's called? They do another thing where they put the needle in the eye and the drops. But either way, whether you do the drops or something else, it's still going to cause like a certain kind of tunnel vision, but it's better than not being able to see at all. It's just the laser eye is more invasive. They have to like intubate these babies again, and they have to paralyze them, and that affects the babies a crazy amount. So imagine a big, have you had a video from Heidi yet for BPD? No. Okay. Well, she's going to put up a video for bronchopulmonary dysplasia. So it's basically a COPD baby that's bigger now, like our big chronic babies that we discussed. So those are the babies that were born like 23, 24, 25 weeks and end up having really chronic lungs. And after that, once you have like a chronic or your version of a COPD, you're having to intubate them and sedate them and paralyze them. It's hard to get them extubated again. So having to go back and get intubated for laser eye surgery is a big deal. So we have to really, really be cognizant of this when we're taking care of our babies. So if a baby's under 36 weeks, under over 36, sorry, I wrote that wrong. No, I didn't. Okay. If we're under 36 weeks, we have our sat limits that are on our, right by where the sat shows on the monitor. So the lowest you want your sat limit to be is 85. If we are on oxygen, the highest you want your sat limit to be is 95. So if we're on bubble CPAP, let's say we're on 25%, you want your sat limits to be 85 to 95. Now, once this baby's saturations start going above this, 97, 98, you wean your oxygen. Yes. So then you keep it within this range. And then when eventually, if your baby's able to stay on 21%, our sat limits go from 85, and then you put a slash, and then the high limit is off, because you can set as high as you want on 21%. Mm-hmm. Now, once a baby is over 36 weeks, you go to 88. So 88 is the lowest they can sat, and 98 is the highest with O2. Once he's starting to be 99, 100, you wean that oxygen. Now, this is every single baby in the NICU unless you're a cardiac baby. Because, for instance, if you have PPHN, pulmonary or persistent hypertension, you sometimes, a lot of the time, we want them to be on a set oxygen, or you're allowed to sat them a lot lower. So sometimes that could be 75 and off, and certain things like that. So, and then you have like a set FiO2, or it could be like leave them on 45% and things like that, or other cardiac anomalies. That it just depends on what's wrong with the baby with the hypertension, or whether you're not having hypertension, whatever it is. Either way, we have different sat limits, but these are the basic sat settings that are non-cardiac. Yeah, so that's really important to take note in. All right, something else we're going to talk about is our gases. Okay, so the gases I'm going to show you are not that of a full-term baby. So if you see this is something you might want to write down, with the pH being 725 to 735, CO2 45 to 55, our PO2 is more 60 to 80, and our bicarbonate-based excess is basically stays the same. Okay. Mm-hmm. So now this is so a baby that's full term, normal baby is going to have a blood gas like yours and mine. So once our babies are premature babies, we like to keep them within this range. And a lot of the time they, for instance, like a 25 weeker that's several weeks old, we like to keep their CO2 more in the 50s because it does prevent the development of BPD, what we're trying to avoid. So we like to keep their CO2 like that. For like an example, if we have a baby on the oscillator and their gases and it reveals to us it's like 728, 57, we clap about that. That's a really good gas. And if it's a premature baby, and that's where we like to keep it.
So preemie babies, you want them to have hypercapnia pretty much.
Yeah, but to them, it's not hypercapnia. To them, that's their normal.
Oh, it's their normal.
Yeah, yeah.
Okay, yeah, because it is 45 to 55 instead of 30. Yeah, okay.
Right. So yeah, if a baby has a gas that's a CO2 of 35, then we are hyperventilating them. basically. So if you wrote those down, right?
Yes.
Okay, so right now we'll get into, I want to show you, I'm going to show you an x-ray real quick just to see, so we can just review tube depth. And then we're going to go into pressure control on the ventilator and the servo. Okay, so this is a really bad gas. Hold on. I'm supposed to cover the names and such. 1 second. I am prepared. Okay. Okay. All right. Can you see it?
Yes.
All right. So those lungs, what do you think about them?
There's infiltrates, fluffy infiltrates.
Yeah, it's real bad.
You cannot see any costophrenic angles. You can see the ribs though, but it's very fluffy. It's a bad x-ray.
Yeah, bad
I don't
X-ray.
see the wait, I think I do see the bifurcation. Yep, right there.
Yeah.
Yep.
And the tube?
Yep, there's the tube.
You know what this tube is?
That's probably the tube feed, or no, it's the catheter. It's the tube
No,
feed?
it is. Yep.
Okay.
So this is what you hit it right on the spot when you said infiltrates. Or sometimes on your test for the MBRC, they'll call it radiolucency and little infiltrates. So that's pretty much PIE, like the pulmonary interstitial emphysema.
Okay.
Yeah. Hello, Kevin.
Hello.
All right, so I would say, you see how right here it says ET tube 7 1/4. So every single RT should be at the bedside for every x-ray. Now, we don't leave it up to the nurses because you always are on the same pages with the nurses in general on the tube depth, but putting the baby from like an incline to where like their head of the bed is at 30 degrees, or they do the x-ray, they put it back flat. And a lot of the time that circuit kind of like goes against their mouth. So it's super important for the RT to be there in that moment to tell them the tube depth when that baby is in position of an x-ray, because it can completely change once you undo the 30 degrees and you go to your side or your belly or anything like that. So a lot of the x-ray techs actually know that the RT has to be in the room if the baby's intubated, so that we can tell them a tube depth. Otherwise, that number won't even be on the screen. They won't take it from a nurse, or they really shouldn't be. Sometimes it happens. But this kid, I think, is currently on an oscillator right now. So we'll discuss more oscillator things, but the tube's in a good position. We usually count the ribs, 1, 2, it's at the 3rd rib, the end of it. Total, we have about 1, 2, 3, 4, 5, 6, 7, 8, 9. We're like the 9th wanting to be the 10th rib because it's so fluffy right there. So, and that's decent expansion when it goes up to 10 ribs. Now, once it exceeds 10, then we're overexpanded, or if it's 8, under 8, then we're underexpanded. So that's a lot of the time how you determine your mean airway pressure. All right, so here we go. Let me go get a fake lung real quick. I'll be right back. Be real quick. Okay, so the servo N, I already checked it before we started. I'm gonna get on here. All right, this is the vent on standby. So there's a million different ways how to change the modes themselves, but just so you can get a look at everything. We have our filter here and our humidifier, and everything's connected correctly. All right, so I'm gonna go to mode. So we're just gonna start on pressure control, and we're doing an SIMV pressure control with pressure support. We'll start with basic settings. I'm gonna just do a rate of 30. Check mark. Our PEEP is 5. Our pressure control above PEEP is 10. I'm gonna go to 15. So I know a lot of places are different in general. Some of the neonatologists actually told me that it's a NICU thing to add your pressure. So if I was in the PICU right now, they would call that 15/5. But over here, it would be described as 20/5 because we count in the total pressure. Just so you can get the lingo of when we are talking about the pressure. So it's 20/5, rate of 30. I time of 0.4 is pretty appropriate for this baby, or a baby. We have a pressure support of 10. So our trigger, and this is based off flow and pressure, and this is a really good diagram to actually show it. So the less it goes down, the more flow pressure, the easier. And then pressure trigger is the negative, so it's a lot harder. So we usually like to keep it about 0.4. All right, so I'm gonna get this baby started. I have the little lung on there. Is it gonna breathe? Is it gonna breathe? Oh, you see it moving?
Mm-hmm.
Yeah, a little bit. All right, so what's something on, so are you more accustomed to what mode?
They usually use a lot of PRVC at TGH.
Okay, and we use a lot of PRVC here too.
Yeah.
So, and PRVC, something you have to be super, oh, let me do this. Just go down. Okay. What it now? Okay, we're good. Okay, so PRVC, what's something that you have to look at a lot and pay attention to, or at alarm?
We usually look at a lot of the PIP.
Yes.
So,
Your peak pressure?
Mm-hmm.
Yeah.
And then, yeah.
Yeah, so yeah, I mean, that's your priority pretty much, and what you base on if the kid needs suctioning, not kid or adult or human, whatever.
Patient.
Patient. Thank you. Thank you. All right, so here, so if we're already on pressure control, you already know your pressure is going to be set. What's something you need to pay attention to?
Plateau.
Nope, we don't have a plateau pressure, because what's something different?
Yes, you don't do that because that causes problems with babies.
Okay, but why can't we? I physically actually can't attain a plateau pressure. What's different in the neonatal world compared to the rest of the world when it comes to their tubes?
There's no cuff.
Yeah. So no, we can't do plateau pressure.
Gotcha. What was the question again?
So if you're looking at PRVC, if you're looking at their peak pressure and having to pay attention to that, what do you pay attention to when you're on pressure control?
And we're talking about a NICU baby here.
Yeah. Any person actually that's on pressure control.
I already said that. We look at the graphics to see if there's a leak. I'm just thinking
Well, there's always going to be some form of a leak with the babies, and it's a huge pain in the butt having to really manage it well. Because a lot of the time a baby can have a huge leak and it looks like they're not triggering the vent a lot, but a lot of the time they're breathing around the tube and getting what they need. So something that's a challenge in here and being able to determine whether a baby needs to be intubated or not is like the amount of leak they could have. Because I've seen babies where it looks like they're riding the vent all the time, but I go ahead and extubate and they end up being perfectly fine. But the leak kind of makes that a little more difficult to determine. So what's something we pay attention to on pressure control is our tidal volumes.
Oh, duh.
You know, compared to PRVC, you set a tidal volume, but here we have to be cognizant of what their tidal volume is, because we give them a certain pressure, and if you're not doing a certain tidal volume, then we're not getting exactly what we need. So here in the NICU, we like to do 4 to 6 per kilo. So if I have a 1,000 gram baby, keep it simple, I want my tidal volume to read anywhere between 4 and 6. So it's kind of odd having such small tidal volume. It would be so this ventilator actually does tidal volumes, like if we're on PRVC, it actually does tidal volumes of like 3.5, 3.2, 2.8, things like that. And we actually do set it like that. All right, let's seal the alarm limits. Okay. All right. So let's say I have a gas, and my gas is, and it's this baby, and my gas is reading 72462, and my baby is 1,000 grams, and it's this gas right here on this baby that's showing on this machine. What are changes that you would make?
You said it's 1,000 gram baby, 7.2462, right?
Yeah.
Well, the normal range is, this is a 45 to 55. So I would do, is it the same as adults? We do the rate.
Well, it depends on what the baby's doing on the ventilator, whether we need a rate or a pressure. So seeing what you see on the ventilator right now, you would have to determine whether you're changing the pressure or the rate.
Yes. So I see the rate right now is 34, 32. And and that's the set pressure on the bottom 15.
So no, so it would be a total of 20.
Oh yes, you did say that. You did say that. So I would decrease the rate.
Okay, let's say, what do you want to decrease it to?
Well, you have a set at 30. So I don't know how safe it will be. Up 28 maybe.
Okay, yeah, actually, yeah, we do it by 2, anywhere between 2 and 5, depending on the gas. So after changing this, your new gas is 72268.
Oh no, that's bad.
Will you write that down so we'll remember what I said?
Yeah.
Because I forget. I'm like, wait, what gas did I give you? Okay.
722 and 68. So we didn't do much.
So you
We will
did
have
the opposite of helping.
Yeah, I did. So I was supposed to increase it.
Right. Okay. So let's say
It was at 30. So
yeah.
just leave it at that. Because it's bad to like switch so fast.
In a way, we give them what they need at the moment. So in this situation,
32 maybe, 32.
Yeah, 32 is okay. So in this situation, I agree for you to choose a rate versus your tidal volume, because if you're 1,000 grams and our tidal volume is showing 4 to 6, that's decent. So we know we don't need to go up on our pressures, because again, you don't want to do any harm to the lungs. So and going up on the rate, so what do you remember what the rate of a normal baby is, or a premature baby?
I know it's like ridiculously high than what I'm used to.
Right.
But no, maybe a normal rate, like a preemie, right?
Yep.
40?
Yep, 40 to 60.
Gotcha.
40 to 60. So this baby right here is only breathing 30 times a minute, 32. So, and our gas was 72462, I said?
Yes, that was the first gas.
Yeah, so that's that the baby's acidotic. And then as an RT, I go to here and I see our volumes are acceptable because it was 4 to 6, but then we're writing the vent. Basically, it's close to 30. So yeah, I would obviously every single time you get a blood gas, we go to the practitioner or the doctor with our own plan. And what I usually do is I make my suggestion, and then obviously if they disagree at the end of the day, you do what they say, but you always have a backup of to why you're doing a certain thing. And if you approach a physician or practitioner, hi, I have this gas, the baby's riding the ventilator and our pressures are adequate because we're doing about 4 to 6 per kilo, so I'd like to go up on the rate to fix this gas, they'll always say yes. you have a backup reason, or maybe you'll deliberate them, or if they completely out of left field disagree with you, always approach them with, hey, maybe can you educate me? Like, why would you make this decision based like versus something else? So yeah, I would have gone from 32, possibly 34, depending on the baby and how they're looking. All right, so let's do another situation. Okay, so let's do, okay. So let's say, let me fix something on the vent real quick. Okay. Let's say you have a 2,000 gram baby. And these are our settings. We have, what's our pressure settings?
40,
No.
wait. Oh, hold on.
So just pretend you're just, oh wait, hold on, let me change this real quick. It's all right. Okay. All right, so what, can you tell me what the settings are if you're telling me the pressure control settings?
Oh, sorry, the pressure control, you have it PEEP of 15 and pressure support of 10. So we would call these settings right here. So we never really say like the PIP necessarily because it can be confused with PEEP, but I would just call that 21/6. You know how I said that we add the PEEP and the pressure control together when we say the settings. So in another hospital, this would be 15/6, but here we call it 21/6. Gotcha.
You're right. So we're 21/6, rated 30, pressure support of 10. We don't need to use oxygen. I'm just gonna, well, I'll leave it. Okay. So let's say we have a 2,000 gram baby and our gas is 72165.
Okay, so
tell me the tidal volume range we would have.
Tidal volume right now, 2,000 gram, well, it says it's 7 and it's supposed to be 46 per kilo. So it's about 12. The tidal volume is 12.
Anywhere between 8 and 12, yeah. Mm-hmm. Okay. So if that's my gas, what would you fix on this baby?
So the normal range is 45 to 55. So we need to, let me see, the rate is 63 and pressure, the pressure is 6 and 15. And you said normal. Well, this is, this is like so many, oh gosh, just gotta answer the question.
So a lot of the time, if I am giving you information and we're playing around with scenarios and such, you can always ask me a million questions back. That's actually something when I'm training somebody for like a position here, or I have a student doing their 12/12s. What I really love, and I feel like somebody's more confident is when they ask me questions back, like, hey, what's originally wrong with this baby? And, because sometimes if somebody just gives you one gas, there's so much more to factor in, So,
okay.
It's okay to ask questions back.
Okay, I wasn't sure because I've never been around you, so I'm just like, I don't know.
I love questions and I'm very non-judgmental, I promise.
Okay, so
promise.
Okay, so you said this patient was 2,000 grams, 7.21, 65, and we're always concerned about the pressure when it comes to the patient, especially a baby. Tidal volume, that I think the tidal volume's adequate. You said it was adequate, but the respiratory rate, you said it's about 40 to 60. So I would increase the pressure.
Yes, absolutely. Yeah, since we're doing 40 to 60, our pressure now is adequate in a sense that this is the low end.
Yes.
So we like 4 to 6, but that it's showing kind of 8 to 9 a lot. Now my arm's getting tired because of what I'm doing. A lot, it's on the lower end. So what we would have more room on is going up on the pressure. So I would get the gas, and in my situation, I would go up to the doctor, the practitioner, and say, hey, this baby's not riding the vent. We're breathing the whole time. I just don't think we're getting enough pressure. We're on the lower end of 4 per kilo. I would like to go up on the pressure. And what pressure would we suggest?
17.
Okay, yeah, that's okay. So that would give us a total of 23 over 6.
Yes.
Yeah, awesome. So then it would give us more pressure. Oh, look at that. Higher tidal volumes. I'm trying to pinch it with my fingers to show it.
Mm-hmm.
There you go. There was an 11. It's hard to do that. Okay. All right. So I kind of want to discuss PEEP in this situation. I'll give you another scenario. Hold on. All right. In the meantime, can you tell me, how do you know if it's enough PEEP? How do you know how much PEEP is adequate, or how do you know when you're giving too much PEEP?
If I'm giving too much PEEP, what I would look at the X-ray.
And what else? Let's say
I would look at the patient. I would look at the patient, see if it's most of the time you can see if they're like when you're giving them a breath, it's super like, I don't know how to explain it. Like
it's like our chest rises too
like
much.
like an overinflation of their chest
Okay.
rising.
So yes, definitely X-ray, because we like around 8 to 10 ribs. Yeah, you always count the ribs. But so let's say you. What's going on? Oh. Okay, it like shut up right when I looked at it. There we go. So okay, so let's say you're in a situation and you have your baby on a vent, and all of a sudden our O's are up, and pretty much the doctor says we want more PEEP, and you had looked at the X-ray and were adequately expanded. How do you know? Let's say you went up to the PEEP. Let's say you went to PEEP of 8. And what would the baby, or what would you see in the room, or what could you determine if it's too much for the baby at that time?
If there's too much, can you repeat that?
How do you know when you have too much PEEP, pretty much?
What I wait, on the vent, right? The patient's on the vent. I would look at the pressures, right?
Okay, but yeah, and your pressures will be higher, because everything that causes your mean airway pressure to go higher.
It would increase.
Yeah, so what happens to your body when you have too much PEEP? Think hemodynamically.
Your venous return, your heart rate, your blood pressure, all that stuff.
Yes. So that's something that happens really fast. Something I also want to include is what was going on in my head? Oh yeah, with gases. A lot of the time here we do capillary gases. So when you're looking at your PO2 to determine things, I do not care what your PO2 is on a capillary gas. Like, I just don't care. Like, if you ever have a gas and you're showing it to a doctor, and let's say your baby's on high oxygen or whatever, You never really tell them a PO2 ever unless it's an arterial gas. And most of the time we do have A lines on the babies every now and then. It's very rare, but they do have their umbilical line. So they have an umbilical venous UVC, catheter, UVC, or a UAC, the umbilical artery catheter. So both those catheters can access arterially or venous. So the only time we really give them a PO2. Also, if I'm getting a capillary gas, it's kind of like getting a venous gas. So your CO2 and your pH. So your pH is going to be a little lower than normal, and your CO2 is going to be a little higher than normal. So even if I had a baby that was like a 7.25/59, I would, and it's a premature baby, I would still be like, hey, that kid's okay, and we don't need to change gas, especially since it's a capillary gas. So it's going to be higher than normal anyways. But yeah, so when you have too much PEEP, your heart gets squished and you have decreased blood pressure, decreased venous return, and all that. So let's say I'm showing you this right here. And let's say this baby is 1,500 grams. And let's say our gas is 72660. What is something that you would like to change on this? And something I want you to take note is this number, 50% oxygen.
Spoon feed it to me.
Okay, but there's a little more to it. There's a little more to it than just that. There's a little more.
So, that pH is good. That's a good pH, but that CO2 is on the higher end, so I need to correct that.
Yeah.
The rate is at 30, and pressure is at 14. So technically, it's at 20, right?
Mm-hmm.
Okay. I would. Wait, where's pressure? That tidal volume's at 7, so that's good. I would increase the rate, but can I do 2 things at once? I don't know. With
Yes,
babies.
you can.
Okay. I don't know. This is you have to be more cautious with babies.
You can.
I want to wean that FiO2.
Okay, okay.
And then I would increase the rate to.
Well, hold on. You can't just wean the FiO2 because then we'll start desatting. What if our sat's only 86?
Oh no, I don't want to do that.
Yeah.
So I would just increase the rate then.
Okay, let's increase the rate. What do you want to go to?
Let's try 33.
Okay. That's not a bad answer. All right. So let's say we're getting a little more of a rate, but we still want to fix this 50%, don't we? How do we fix that 50%?
What do you mean? How do I fix it? It's at 50, and we're not worried about what you said. What was it? A cap gas? We're not really worried about the O2, correct?
I mean, whether it's cap,
I
haven't given you a PO2.
No.
So if you're asking me for a PO2, I would say the PO2 is about 35.
Oh no. We need to increase it.
Increase what?
The FiO2.
PO2?
Yeah, the
Okay.
O2.
But we don't like to give babies a lot of oxygen. So what else can you do?
PEEP.
Yes. What do you want to go to?
8.
Okay. We'll do one at a time. For this one, we're a little more conservative.
Okay.
Because we have to see, because so now that we got a PO2, we actually have a line, and then you can actually look at their blood pressure easily on the monitor, or you can take their blood pressure. Sometimes, like even if a nurse is not available and I'm manipulating vent settings, I'll go ahead and put a blood pressure cuff on a baby and see what the blood pressure is, you know? So if you don't have it in real time like you do for a UAC.
Mm-hmm.
So yes, you went up on the PEEP. So now that you've gone up on the PEEP, my baby's FiO2 went down to 40. And so if you notice this, now our pressures went to 21/7. Yes. So we have something I just want you to remember is with our orders. So now that we went from 20/7, now it's 21/7. So when you're reading that back to a doctor or when you're giving the person next report, you would have to remember to say 21/7 and not 20/7. I mean, yeah, 20. So you have to say the right 21/7 because since you went up on this, it changed the total pressure. Does that make sense?
Mm-hmm.
So we're 21/7. But pretty much a lesson in that is just to not be afraid of PEEP in general. I feel like it's almost rare on a ventilator to keep a baby on a PEEP of 5. They're always like on a PEEP of 6, PEEP of 7. But also I'm going to talk about, so why do you think we want to get rid of pressure control? Why do you think I think it's an opinion to like not prefer pressure control for these babies?
Because they're not, the tidal volume is not adequate. Like
In
it's,
those situations, yeah. Well, I mean, just going up on the pressures, you can make their tidal volume adequate. But what's happening when you go up and down the pressure so much?
Oh, the venous return and all that stuff.
Yeah, but that's more like keeping an eye on their mean airway pressure in general. So what I'm trying to get at is, yeah, pressure control is easier to manage, especially when they don't have a cuff, because you can manage exactly and have more of a steady pressure because a lot of the time it's really hard to manage how much tidal volume they're getting. Whereas when a baby does have a leak and we put them on PRVC, their pressures go wild and crazy high. So sometimes that's why it would be preferable. But the damage that's being done to the baby's lungs by choosing pressure control is mandating that amount of pressure every single time. So having a pressure of like 30 and getting pounded 30 times a minute, and sometimes you don't need all that, especially with the pressure support, and then including in accidentally overventilating a baby, that it just causes more damage. So we try to nowadays more so promote spontaneous breathing as much as we can. So a lot of the time I actually avoid really going up on the rate when they don't need it. And that's why we're going to introduce you guys to auto mode and NAVA and things like that, because those babies are able to spontaneously breathe until they're just not breathing, and then the vent will kick them in with a pressure control. So like on NAVA, we a baby, and we'll get into what it really is, but they'll be able to breathe spontaneously, but their backup settings are going to be pressure control settings. So it's really rare to get into. I just wanted you to be able to be kind of practicing kind of their volumes and what kind of volumes babies have and what we wean or what we don't wean. But it's we're touching up on pressure control, but it's probably not something that y'all are going to learn a whole lot, but it's a good base to start at. But it's already 2:00. Look at that went by quick. Do you have any questions?
No, I'm just upset that I'm not
here.
Yes, and it feels like I learn more when I'm there, and it feels like my brain is like turned off. It just upsets me because I feel like I know the information, but just clinically.
I mean, you did really good. No, this isn't. I know you're not accustomed to exactly how we do things, and it's really hard getting used to such tiny tidal volumes and putting that into reference on how to fix a baby. So no, I love questions. You did great. I promise. You're just fine.
I just don't know you, and I don't like my impressions. I don't want to feel like, oh, she's a dumb student. And
No, I never
she-
think that. I think
Like-
you're smart.
like how did she make it this far? She doesn't know what she's talking about. Like it's very important to me that
Yeah.
that I know what I'm supposed to know to get on later. Like, you know, it's
Right. No,
very
but
important.
I also understand. I mean, I came from HCC and right in here into the NICU. So a lot of it is like, this is all I know, but I just having you guys, like, I think I started students a year or two after I started working here, but I still remember what it's like being a student. So this is why at your regular clinical days, all the videos you're going to see is things that we do on your first day at clinicals. We cover so much just on the first day, so you're prepared to be out there. And it's a lot of brand new information. It's a whole different world. Like, I came up into this job feeling like I didn't know a thing. Even in my interview, I'm like, what should I study? I don't know anything. And they're like, we know you don't know anything, but you'll get used to it. So it's just getting accustomed to just the different numbers, basically, because you kind of treat them the same in general. It's just the numbers are different, but you're going to be just fine. And you're here to learn. You're good. It'll be fun.
It's more of a struggle for me because I know you guys are the only ones that you guys pick who you're going for 12-12. So I'm just like, oh my God, I don't know anything.
So do you like the NICU?
I like it. It's
Or what you know of it, I guess? Or do you like the idea of being in the
I
NICU?
like the idea, and a lot of RTs at my job, they're trying to push me to go to NICU because it's more rewarding, because it's, you know, you're actually saving a baby, and a baby could live their life, not like a 80-year-old patient. So
that's what I love about it too.
Yeah.
Do y'all get to go work at Advent right when you into the NICU, like when you get hired?
I haven't heard of many RTs that gone there, but if they really like you and you're really good, then yes, they will.
Yeah.
So I guess this is kind of same for you guys. So
yeah,
I don't know.
Yeah. Well, I'm sure there'll be a lot of things changing and flipping around here. So there are opportunities. But yeah, I know it does stink. I hope that all this changes soon, but no, just keep doing what you're doing. You did great. It's really hard to do this through video, but just keep in, if you really, really want the NICU eventually, you just kind of got to keep in contact with like our manager in general, or just even shooting messages. Like if you're like, I was obsessed and they hadn't even started hiring students. They had one student before me. And once we got the information that they even like think about hiring students, I had gotten his email and I like bugged him pretty much. Like, you just got to really be aggressive. I would randomly message him or send him emails and be like, hi, we just finished our 12-12s here, because I didn't do 12-12s here. And I'm just keeping you updated because I'm still very interested. That was annoying. But here I am.
That's good. Okay. Thank
so
you.
how many more are you? Okay, so is it working like whenever a clinical instructor just puts up that they're going to do a video, y'all just log in when y'all can and you're...
Yes, because everything's linked through Canvas and our email. So we get a notification from Canvas and we get a notification on our email. So we're pretty much given like twice, you know, but yeah, like I saw it like this morning. I'm just like, what? I thought it was tomorrow, not today. So I was just,
it's tomorrow too. Yeah, Heidi has one tomorrow.
Okay, so I was just like, yeah, we see it right away and it does work. So
yeah. Okay, well, I might see y'all too because I'm at work tomorrow and she's going to do her video tomorrow. So
okay,
I'll hop in and say hello.
Okay, thank you
But
so
you
much.
have a good day.
Thank you.
Yeah, of course. Let me know if you have any questions. Okay.
Thank you.
Bye.
Bye.